Welcome to this session on contemporary lung scanning. It's encouraging and I guess a little disappointing to see already that we're packed out, and obviously underestimated the interest that remains in VQ scanning. We've got a great selection of speakers for you today, names that I'm sure you'll know many of. So we'll get started and look forward to a very interesting session. I'll hand over to my co-moderator, Professor Henry Royal, to introduce the first speaker. I just add that there's about 5 or 6 free seats down at the front. If anybody's planning to stay for the entire session, I'd encourage you to come and rest your legs. And it's my pleasure to introduce the next speaker, Associate Professor Paul Roach, who's the head of the Department of Nuclear Medicine at Royal North Shore Hospital. He's going to ask the question about planar SPECT and SPECT CT, and I suspect the question at the end is going to be who's still using planar. Thank you, Paul.
Well, the question at the beginning is going to be who's still using planar. So who is still using planar in the room? All right, not too many hands. Henry, I can't see your hand. Is it going on? Yeah, okay. All right, well, clearly this talk is aimed at you. So I want to take you back to 1964. So this was the first description of the lung scan by Henry Wagner's group. And since then, it's been amazing how nuclear medicine has changed, and particularly one of the key things has been the move from planar to SPECT and more recently to SPECT CT. And that's happened across the board, but not in all places and not in all countries, and the lung scan stands out, and particularly in the US, where it's still very much a planar technique. What are the problems? Well, firstly, you have all the issues around the probabilistic reporting that came from PIPED. People like Lenny Freeman have done their best to try and move away from that to more of a trinary reporting approach. Look, the referrers want an answer. They don't want a probability. They probably want the correct answer, of course. But so, it is a real problem. Then you have the other issue, which is around the limitations of 2D imaging. And in terms of lung scanning, they are significant. So firstly, there is significant overlap of segments and shine through from underlying segments. It's difficult to estimate defect size. Not all segments are actually visualised on a planar lung scan. For instance, you don't see the medial, basal, right, lower lobe. We all know there's significant intra-observer variability. And in the same way, moving from 2D to 3D anatomical imaging of the lungs, you expect that moving from 2D to 3D scintigraphic imaging of the lungs should be better. Now, the literature supports that, and in the interest of time, I'm just going to summarise it. But certainly all of the papers, which I've quoted there, show an improvement in sensitivity, typically from around 75% up to 95%. And a few of the authors of these papers are sitting in the front few rows at the moment. And this is not just at the subsegmental level, but also at segmental. There's also an increase in specificity, and that's been consistently shown. Just to highlight 2 studies, one is from Aachen in Germany. So you can see there in 83 patients, sensitivity went from 76% with planar up to 97% with SPECT. Are you leaving? No. Oh, okay. He's heard it all before. And the specificity, of course, is much higher. I can sit up here, Dale, don't worry. With another paper, and this is from Jan's group in Copenhagen. So again, high SPECT sensitivity of 97% and specificity of 88%. So well and truly superior to planar. The number of intermediate results drops to less than 5%. Marika, who you're about to hear from, she's got a very big paper showing a 1% intermediate rate. And remember, this compares to the PIPED study at 39%. Michel Leblanc's group have shown a very high negative predictive value, and certainly a reduction in intra-observer variability has been shown. All right, a couple of cases for you to have a look at. So planar lung scanning, does it look normal? Anyone see any clots? When you do SPECT, you can see that you actually do see a few clots that are arrowed there. And the problem is that you're taking away this overlying part of the lung. You actually finally get a good look at the different segments. And this patient was PE positive on CTPA. Scan from our department, so there's definitely a clot there. Does anyone see anything else anywhere? Again, probably not a lot. Have a look at that area up there, though. A little bit down, maybe. But again, once you have the SPECT, you actually got the lingular out here. And the reason you don't see it is because of this overlap. So it's not just at the subsegmental level you're picking up clots, you're also picking them up much bigger. Another case from our department, so there's obviously a mismatch at the right base. Does anyone see anything else? So at this point, this is an intermediate probability report that's about to go out. And again, when you have the SPECT, you actually see there's a lot going on. So 1, 2, 3, 4, 5, 6, 7, multiple PE, completely different report. So what do you need to do VQ SPECT? You obviously need a SPECT scanner, and they're fairly prevalent. You need a decent ventilation agent. Ideally, you want something that maintains its distribution over time, should act like a gas, should have good imaging characteristics, and is safe. Obviously, Xenon doesn't tick those boxes. It has poor spatial resolution and low energy. There are certainly options around the aerosols, technetium aerosols, DTPA and colloid. They're widely available, inexpensive, and the image quality is good. Technogas, of course, is better. It's a smaller particle, has better alveolar penetration, and it's static. Krypton is another option. It's used mainly in Europe. It's fairly expensive, and you have to do a continuous administration. But that's what a Krypton scan looks like, so image quality is quite good. And of course, if you're doing the technetium agents, you have to do them sequentially. So that'll take you about 15 to 20 minutes to do. If you're using Krypton, you can do it simultaneously, so that'll be a 10-minute scan. All right, so if you don't have Technogas, what about DTPA? Well, Marika's group have published on this. So again, the image quality is very similar in patients with fairly normal lungs. The problem is when you get to COPD, you get much more central clumping with DTPA than you do with Technogas, but the image quality is still satisfactory. Do you need a ventilation scan at all? And some have certainly pushed this. Maybe you just do perfusion only or perfusion and a low-dose CT. So again, Jan's group published on this in the paper that I'm going to quote a few times in this talk. And they found that doing that drops the specificity quite significantly from 100% down to 51%. And you will have a higher non-diagnostic rate. So we would definitely recommend a ventilation scan is done. You need validated reporting criteria. The EANM criteria are what we use, I think what most of the world uses, and I think you're going to hear about this in the next talk. They've been well validated, so Pierre-Yves Leroux's group from Brest in France looked at this. So in a big paper, 249 patients, they really found it was quite robust, separating P negative, P positive. And Marika, I'm sure, will talk more, but the criteria that are used are greater than one segment or greater than two subsegmental mismatches. The same group looked at outcome, which is important because there's some literature around this with CTPA. So they found that in 393 patients with a 28% prevalence of PE, the 3-month thromboembolic rate from a negative scan was 0.38%. Now, what about if it's all too much, you really do want your planar imaging? Just remember that you actually can generate planar imaging from SPECT data. You can do it through a couple of techniques. One is angular summing, where you take a couple of stops on the SPECT scan and you can generate these. The image quality is fine. The only thing is, because you're acquiring data over an arc, you can blur out small defects, but this is commercially available on several packages. Our group, and Dale particularly, worked on a reprojection technique where you're using all of the counts. So you actually get really good images that are absolutely planar-like, but that's a little bit more complicated and less commercially available. All right, so why change? Well, obviously, we're in the era of CTPA. And CTPA has a lot of advantages. It's quick, it's available, images the clot, it's a binary report, and it's specific. And it certainly shows other pathologies. There are disadvantages, and you're going to hear more about this on Monday afternoon, but the sensitivity is not as good as with VQ SPECT. There's obviously issues around breast radiation dose, contrast, and suboptimal studies, particularly in groups like pregnant women, and Jeff will be talking a bit more about that on Monday. So I think, though, if you think that this is going to cut it against that, you're kidding yourself. And the key point I'd make is relevance. If we want to stay in the game, we have to be relevant, and we have to do the test as well as we can. Which brings me to SPECT CT. So what you're doing here is you're combining a VQ SPECT with a low-dose CT, and the aim is to characterise the cause of any perfusion reduction with the low-dose CT. And this has been shown to improve the accuracy and particularly the specificity of VQ. Now, as you know, a low-dose CT will show a lot of different processes: pneumonia, pleural pericardial effusions, lesions, pulmonary infarct, which of course could be accounting for the patient's symptoms. Do scans from our department, so consolidation, pulmonary infarct, mismatch down at the right base, match down at the right base, and you can see this was due to an area of consolidation that was not known about, wasn't seen on the chest X-ray. And look, in general, mismatch equals PE and matched equals other things, but as you know, in medicine and in life, it's not always that black and white. And so in general, mismatch defects mean PE, but there are other causes: vascular compression, for instance, from carcinoma or lymph nodes, emphysema, radiation therapy, vasculitis. And these might, and the advantage of doing the CT is it helps you characterise some of these things. So this is a nice example from the Arkin paper. So you can see that there's obvious mismatch at particularly the right upper lobe, probably the left. Is this PE? No. No, says Marika. She's seen this before. What's going on here is that when you've got the CT, you can see that you've got a lot of bullous lung disease up there. That's why there is no perfusion in the upper lobe. So without the CT, this would have been a false positive. So you do need that anatomical information which SPECT CT gives us. Just a few examples from our department. So there's mismatch down at the right base. But with the CT, you can see it's actually a focal area of bullous disease, which is explaining that perfusion reduction. Here's another one, sort of more medial in this case. There's clearly mismatch down at the right base. Is that PE? No. So what you've got here, it's very prominent vasculature, the bronchovascular bundle, and that can actually come out quite peripherally in some patients. So that's why having that patient's individual anatomy to look at can be very helpful. Another case, so there's some mismatch in the right middle lobe. Ventilation's down a bit, perfusion's down more. Is this PE? So again, with the low-dose CT, you can see an area of gas trapping. That's why the perfusion is down. So these are lovely images. Does it make a difference? So going back to Jan's paper from Copenhagen, so I've shown you those results before. Let's add the CT. The sensitivity does not increase. All right, so SPECT CT will not improve sensitivity, it improves specificity. And you can see here that very strong results in this study of 81 patients with perfect specificity. A group from Perth in Western Australia replicated these results, similar number, and again, very high specificity. So the value of the adding the CT is that you can characterise the cause of perfusion defects. So these might be pathological, things like pneumonia, pleural pericardial disease, pulmonary edema, etc. Patient-specific physiological things such as fissures and vessels, and I think Jeff will be talking more about that later in the afternoon. Also the false positives. So, you know, there are other causes of mismatch, and adding the CT can show that. Your specificity and accuracy will go up, and your inconclusive rate becomes very low. The downsides, well, of course, it's adding 1 minute to the acquisition. The radiation dose is there, but it's very small, typically 1 millisievert from a couple of publications, and the breast dose is very low. And on Monday, there'll be a lot of discussion about radiation exposure with CTPA and with VQ, so come along to that. So I guess the options are you could do it on selected patients, you could do it on all patients. I have to say in our department we do it on the majority. Young females we're more careful about. If someone clearly has an abnormal scan, we may not do it. A progress study, we may not do it. But certainly, and one option you've got is to actually do the VQ SPECT, have a look at it, and if there's any abnormality or anything you're not sure about, then get the low-dose CT while the patient's still on the bed. One philosophical thing I would say is that I think it really is in our interest to try and maximise the accuracy of the study. So, because if you put out an intermediate report or an inconclusive report, that patient is going to go down the corridor and have a diagnostic CTPA. So it's another radiation test, which if possible we should be trying to avoid. It's also said we'll use the chest X-ray as a triage. So if it's a normal chest X-ray, do a VQ. If it's abnormal, do a CTPA. Would anyone do a lung scan in this patient? Yeah, Marika would. Okay, well, as it turned out, so did we. All right. It's good to have this audience participation from Marika, isn't it? So anyhow, the ventilation scan is a bit patchy, as you'd expect. What's the perfusion going to look like? Is it going to be horrendous? You know, so it's actually it's a good quality study. So even though the CT looks so terrible, you know, the VQ SPECT was in fact highly diagnostic in this case. So this was a case of lymphangitis. Oh, I've got a dead mouse here. Oh, there we go, lymphangitis carcinomatosa. So look, I think we've moved on. You know, the days of having a planar lung scan and holding a chest X-ray up, they're over. We're now in the world of co-registered ventilation SPECT, perfusion SPECT, and in many cases, and increasingly, the world of SPECT CT. So in summary, compared with planar imaging, for the few of you in the room that are doing it, just remember that SPECT is more sensitive, it's more specific, and that specificity goes higher again when you add the CT. It's more accurate, it's more reproducible, your non-diagnostic rate becomes very low. The scans are faster to acquire, your technologists will love you, it's much easier to do than planar imaging. Your reporter confidence will be much better than with planar imaging. So for those of you that are still in the world of the 3 Ps, planar, pipette and probabilities, I think throw them into the history of medicine textbook. And I think that Mike Graham, I think, makes a very good point in this editorial from a few years ago. It's now time to move past the pipette approach to VQ and adopt the most modern methodology. So look, the 1960s was a great time, and there were lots of good things that came out of it, but really we need to move on. And luckily, if you go from 2D to 3D, you don't have to sit there and wear these silly glasses. This is reserved for people like this at Photo Opportunities, and God forbid people like that. But my final slide is for us to stay relevant in the game, we need to be doing the test as well as we can. And I think, you know, everyone really should now be in a SPECT world, and I think increasingly we should be in a SPECT CT world. We are trying to pack a lot into the 2 pulmonary sessions, so I really haven't had a lot of time to go into any of our technical or acquisition details and so on. But if you want to read a bit more about it, there are 2 references that I'd push you towards. One is the November 2010 seminars in nuclear medicine that Lenny let Dale and I guest edit, and also a review article from the EANM from 2013 that we did. So that just goes into a lot of detail about our acquisition parameters and so on, if that's of any relevance. Thank you.
Questions for Paul?
So in the scenario where you've got patients that are unable to have a SPECT, do you still go back to planar, or do you go along another?
Very, very rare that we would encounter that. But I mean, obviously there's always that option. And, you know, look, occasionally I guess you'll have a patient where you know that the only thing you're going to get is like an anterior posterior planar, and that's better than nothing. And look, I guess then you just have to qualify your result to say, look, there's no massive PE going on here. You can't, there might be some small subsegmental things that you're going to miss. But I have to say it's very, very rare that happens now.
Most diagnostic algorithms would say pulmonary CTA first. Why do you think that is, if the sensitivity and specificity of VQ SPECT CT is so high?
Well, that could take us, that's a question we should sit around the bar and have a drink to discuss. Look, I think it's multifactorial. I mean, I think that, you know, to be honest, I think in the US in particular, which dominates things, the lung scan is done suboptimally. CTPA came along. The clinicians get an answer. That's what they don't want, a probability. They want an answer. It's very clear that I think the respiratory clinicians want other information, so they want to know if there's any other pathologies going on. CTPA is very good at that. Then you have all the issues around access. I mean, we have a 24-hour service, but I know in many parts of the world that's not the case. And so, you know, you can't really say after 5:30 or 6 o'clock at night, we don't offer the service, the patients go for CTPA. So I think it's, I don't know whether Gary wants to add any of this, I think it's multifactorial on that count.
Henry, exactly what you say. Western Australia, 2017, their guideline algorithm for investigating pulmonary emboli comes down to lung scans and says, if high probability do this, if low probability do that. So they're still using the hangover from pipette, planar, xenon and aerosol. And I think that's why a lot of the algorithms, they've been written by people who don't know what they're doing.
You're not saying Americans, are you?
Okay, thank you, Paul.
The next speaker is Professor Björn Jonsson. Sweden has a very proud and long history of not just thinking of lung scans in terms of PE, but also making physiological measurements. And Björn has been one of the great contributors over many years, and he's going to share his experience with us. Thank you, Björn.
Dear Chairman, ladies and gentlemen, I thank first World Federation for inviting me to give this lecture. And I'll talk about 40 years of experience and challenges in ventilation, perfusion, SPECT, and these challenges are not over. They are just beginning, I think. If we go through some of the hallmarks of the development, in 1964, as previously said, the first scintigram was performed to do PE diagnostics. And a decade or so later, we had some small patient materials. SPECT was born just 40 years ago, and it started with the myocardial SPECT, and that was, of course, fitting the size of heart, fitted the size of these days gamma cameras. It took a while before ventilation perfusion SPECT was performed, and Corbus et al. Already in 1997 presented about 1,000 cases, and he showed that you could give a proper reply to the clinicians in 96% of the cases. In these days, still one performed perfusion scintigraphy first, and then after a few hours or the next day one performed the ventilation scan. But we developed a technique presented in the year of 2000, where we showed that you could do ventilation before before perfusion, and the whole procedure could be finished from referral to report in 1 hour. We took the challenge to develop this technology for ventilation perfusion SPECT, and with Palmer, our excellent physics, we showed that we could do the same thing with the same low dose of radiopharmaca, also in 1 hour. And since then, we have seen lots of studies with Bike, Reinhardt, and several others showing the excellency of ventilation perfusion SPECT in the diagnosis of PE. And EANM guidelines, as have been discussed by Dr. Bike. So still, these guidelines are important, I believe, and we are working, as Marika told you, about an update. We need one single method. We need to standardize it because, as I will come back to, we need large materials for the research in the future. And it means a standardized test with standardized recording and standardized interpretation. Our challenges continue. Notably, in the United States, there are still a lot of people arguing for planar scintigraphy. I don't believe it. I don't like to believe it, but that's the case. Another challenge is, of course, the relationship with CTPA. If we make a brief comparison between SPECT, ventilation perfusion SPECT, and CTPA, we have a weakness. That is, the availability of ventilation perfusion SPECT is low compared to CTPA. And that's the only reason why CTPA is indispensable in the clinical routine. On the other hand, CTPA has a large number of contraindications, and very frequent contraindications in with different materials, 20 and pioped up to about 50%, and that makes VP SPECT indispensable. So both these techniques are a must in our clinical world. If we go further and look at the non-diagnostic studies, VP SPECT is advantageous. It has a higher sensitivity. It has about the same specificity. Both CTPA and VP SPECT are very sensitive indeed. The radiation dose in the clinical practice, in the clinical routine, is still about 4 times higher or more for CTPA than for VP SPECT. Particularly the radiation dose is very significantly higher. So VP SPECT should be done in young women particularly. Additional diagnosis. The radiologists always tell you that CTPA is unique in its ability to provide alternative diagnosis. As Marika has told you, this is not the case. We have very important additional diagnosis from VP SPECT. And as a matter of fact, the rate, you have higher rates documented for SPECT than for CTPA. Chronic pulmonary embolism, CTPA is nearly useless, but while VP-SPECT is the gold standard. And I repeat that for research and follow-up, we have the advantages with VP-SPECT are very significant indeed. So VP-SPECT merits promotion, and we have to look for the challenges, because still CTPA is the most commonly used technique if you look at worldwide. And this is a challenge for us. We must do more research. We must educate people within our discipline and within our clinical cooperators. We need to increase the clinical utility of this test and particularly its availability. If you go for research, if I will go very briefly through that left heart failure, already Fazio and others in 1978 told you that there will be a redistribution of perfusion towards higher regions at left heart failure. And this research has been continued within the Marika Bikes and my group. If you go for the COPD, there are lots of early case reports and things like that. But later on, it is mostly the Lund group and Marika Bikes group who is pursuing this field, not only to diagnose COPD, but also to grade it from normal to severe COPD. And it's a very common additional diagnosis, as Marika emphasized. Pneumonia, since long it's known that will cause specific signs. The stripe sign, as demonstrated by Sostman et al. Many years ago. Later publications, again, Marika, and chronic thromboembolic pulmonary hypertension. Where is the evidence? Very few studies, but very convincing studies, because even if there are few publications, it is regarded as a gold standard. So, what do we see today in research? We have small research group, and all of these research groups are doing a good job under their circumstances. But what do we need? We need large interdisciplinary and international multi-center studies. We need to cooperate with our clinical colleagues, and we must focus on systematic follow-up and clinical utility of this wonderful technique. With these research results in our hands, we should strive more to educate, as we are doing here today. We are issuing guidelines, but we need to do more. We need broader international efforts, courses, cooperation with our clinical colleagues in our congresses, and we should go to their congresses and present our data. Clinical utility is maybe the greatest challenge we have. Most studies are focusing only on PE. We should broaden that. We have a poor availability, and we must strive to increase the availability. All these challenges in research, education, and the clinical utility, we should regard them as a combined challenge. What to do about it? The research data should lead to more education. But I also think that it is very difficult to educate thousands of nuclear physicians around the world and tens of thousands of clinical colleagues. I believe that we should go in the direction of centralized reading that will increase the clinical utility by increasing the availability and increasing the quality of the reading. But this centralized research must be based on large studies. And finally, not finally, but on our way, we must increase the computer assistance in the reading to provide the reader with more prepared data, making it easier for them to read. One can say that artificial intelligence is a danger, but if you do that, you will stay behind the development. It will take time, but we should use this time to do more research, to collect large materials which are performed with similar technique, with similar interpretation criteria, because that is a must before we can go into the field of artificial intelligence, to increase the utility and to increase the availability. These challenges should be addressed. Who will lead this? Still, I believe that you need clairvoyant entrepreneurs in this field as in every other field. We also need the support from the industry, because the industry must provide us with cheaper methods, automated preparations of our radiopharmaceuticals to make it available on a 7 by 24 hours system. Who will take the lead? Will the societies do it? EANM is particularly well situated because in Europe you can work with large funds from United Union. But who will start the leaders? Start it up. SNM staying behind so far. World Federation of Nuclear Medicine, maybe. I will not propose who will take the lead. With this lecture, I have spent more than 40 years in the field, and for me, it's soon time to say farewell to arms. Thank you so much.
Thank you. Does anybody have any questions for Professor Jonsson? Yeah.
As a dual-trained radiologist, I agree with all that's been said today, but as we know, pulmonary embolisms are a continually evolving process in one patient. And I've seen a number of patients with large saddle emboli, normal BP specs. How do we resolve that?
Yeah. That is a question which we get now and then, and
So let me repeat the.
On the basis of these extremely rare.
Could you use the microphone so that everyone can hear you?
It hasn't been rare in my case.
There are saddle embolites, which cannot be seen on ventilation perfusion SPECT. But with any method, there is a loophole. And we have a loophole in that aspect. It's very rare if you make these large series, you hardly see them. But in the very experienced clinicians, they have it. They see it, and we must admit that we can't see everything. We see 99.5 or so of the cases, but still there is a loophole somewhere. And that is not unique for our method. Of course, CTPA has their loopholes, which are much, much bigger and more frequent.
Thanks. Thank you. I just add that. Oh,
Sorry, can I just make a comment? I always do a dynamic study when I do the perfusion injection, and so you can see the main pulmonary artery. So if there's a clot stuck there in there or the right ventricle, you can see it. And this has happened once in my career, so it is very rare.
If you have an evidence, I haven't read the evidence, but I think it sounds like a very good idea.
Thank you. Can I just add that if you're interested in pursuing further the uses of quantitative VQ scanning, that there is a dedicated GE breakfast session in this room Monday morning at 7:15 where Marika will be presenting. So I encourage you to follow on and attend that meeting. Thank you.
Okay, our final speaker is Dr. Jeff Shumbury. He's going to challenge all of us with some interactive cases.
Put that there. So you're all still here. Well done. It's interactive for those of you who are not technologically challenged. And for once, I'm going to encourage you to use your phones during a session instead of being upset when you do. If you go to the app that comes with the this conference, if you choose the session that we're in, which is the Pulmonary 1 session on Saturday afternoon, when you select that, it comes up with a little thing at the top that says, this is an interactive session, live, it's go time, join the session. If you touch that, it should go live, and then you can vote in real time for some of these things that we're going to show you. So, thank you to everyone for being here. Thank you for being invited, people asking me to talk on the last session of the day on Saturday. And we're just going to talk about, to put that up there. So we're going to talk about lung scanning and some of the things you might like to see. I'd like to welcome all our guests from overseas to Australia. It's a fantastic place to come. He says, trying to get... Oh, there you go. So, physiology is the key. I normally tell my children that life is physics, but for this audience, life is physiology. Ventilation and perfusion should be well matched in our normal lungs, and that completely underpins what we're talking about. And I'm going to skip that because I think Paul's really covered a lot of that for us. But I think one of the things you need to know in your physics is count statistics. If you get a poor quality study because of low counts, you will be looking at data that will make your life much more difficult. And as you can see here, if that works, there you go. This is the same patient. We gated this patient to acquire the data so I could segment it any way I liked. This is using 1/6 of the data, 1/3 of the data, all the data. And you can see the increasing noise that you get if you have poor count statistics. So make sure that when you do your study, you have adequate statistics. I'm just going to skip that as well. So the other thing you need to understand about the physiology is that it makes a difference whether your patient is lying down or sitting up. So on the left there, you have a patient sitting up, and on the right, a patient who was lying down at the time of their injection. So make sure that you do your patients lying down, we would recommend, and that you have a standardised approach to all that. DTPA aerosol, if you use it, comes with its own issues, and one is that it's absorbed. If you've got any kind of lung inflammation, you'll get rapid absorption of DTPA. It might trick you when you see things like this. These are kidneys in a patient who's getting very rapid absorption. Of course, if you've got something that's rapidly being absorbed and you're trying to do SPECT, that's going to produce even more artefacts for you to have to deal with. Okay, this is what we call the rind artefact. So on a planar image, I think most of us used to appreciate that there were more counts at the back than there were at the front. And I think we all thought that meant the lung was a bit thicker at the back, so there was just more tissue to see. But then we did SPECT, and we found in some patient, you've got this amazingly linear artefact. What was this? So we did a little bit of work and a little bit of thinking. So this is a diagram of lung. So on the left, you have lung. If you've just immediately lain down, taken a nice big breath, all your alveoli are roughly the same size. But as you lie down, the lung compresses posteriorly and it opens up anteriorly because of the gravity gradient. This is called the Slinky effect, and it's been well documented by some guy who did MRI studies in a plane at 0 gravity, and I want that job. So To prove that that was the case, we actually did a study where we did the scan on PEEP. So this is the same patient at normal rest. You can see they've got the rind. We then made them breathe on 16 centimetres of water PEEP, which is not very pleasant, but they volunteered. And you can see that we made the stripe sign go away. So we're quite comfortable that this defect is due to dependent collapse of the lung that occurs while you've got the patient on the bed waiting for their lung scan. It's worse if they're big. Okay, the next thing you want to know about physiology is what we call the fissure sign. So as we all know, the lung has a number of fissures. And along those fissures, we often will see reductions in counts. Now, it's not all the fissures, and it's not always in the same patient, but you'll regularly see, and I think it's particularly common at this confluence of fissures on the right. So why does this occur? Okay, seemingly not quite working there at the moment. So the fissure sign we feel is due to lack of penetration of the of the MAA all the way to the pleural surface. So if you look at pleural surface of the lung, the alveoli extend beyond the terminal capillaries. So your MAA is going to impact short of the surface, but the technogas will get all the way out. And of course, at these pleural reflections, you've got a double thickness of that effect. And so you'll get areas here where perfusion doesn't make it all the way on both sides, but the ventilation does. And so you'll see linear areas of reduced uptake. And the trick again, as Marika keeps pointing out, these are not segmental, these are straight lines. If you do a spec CT, you can align them again. What else can go wrong? Well, there are these little spots appearing on the lung. Does everyone know what they are? These are pulmonary emboli that our tech has caused because they had some difficulty with the vein. You get a little bit of blood clot, and the techie sticks to the blood clot, and you get hot nuclear medicine pulmonary emboli. So we've diagnosed pulmonary emboli, but possibly not the way we would like to have done so. You also need to be aware that your patients will sometimes try and trick you, and they might have shunts. So be aware of things that you're not expecting. So here's a lung, vent and perf, very large match defect. Of course, the patient has dextrocardia, and nobody bothered to tell us that. So I'm now going to give you some interactive cases. We'll try and keep it moving along because it's getting late. We'd all like to go out and have a drink. This is a young lady. She's a 34-year-old woman. She's been previously well, no history of anything. She's had sudden onset of pleuritic chest pain. She's got a slight fever, but she's not on the pill. She's had no recent travel. She's a non-smoker. She comes for an investigation. Her chest X-ray is completely normal. And we do this lung scan. So here's the lung scan images. I have ventilation on the top. I have perfusion images on the bottom. I'll give you a second to have a look at those and maybe help you out by saying, have a good look at these ones, particularly the coronals. And these are some more images from the patient in a different plane. I quite like coronals. So here you will get a chance to vote. What do you think's going on? Does she have infection? Does she have something else that's not embolic? Has she got lots of little PE? Or are you just hanging out for dinner and you're being polite? I'm not quite sure how I activate the counting. Oh, there we go. So multiple small PE looks like the winner. Well done. That was certainly our first report that went out in this patient, was that she had multiple small PE. Okay, thank you. However, and I'll show you those PE, you can see quite nicely there are multiple small perfusion defects here and here, and again here and here. She came back 9 days later after she'd been put on anticoagulation. She came back because she had some more pain. And we had a look, and this was the perfusion at baseline. This is her up-to-date study, and you can see there's one small new perfusion defect. So what would you do now? Are you going to do a venous Doppler? Just going to watch and wait? Maybe it's time to get that CDPA, put in a filter. No, I'm still just hanging out for a drink. Okay. There's a few of us waiting for that drink. Well done. But most people want to do a Doppler or a CTPA. I actually think I would probably just watch and wait. It's only 9 days, and she might have had a little bit of clot fragmentation, and maybe it's just moved along. So it's probably a bit early, I think, to be jumping in and doing more. And that's what we did, though. I think if you want to do a Doppler of the legs, that's okay. There's a drink for those who wanted one. Okay, she's now come back at 5 weeks. They wanted an early follow-up because of the changes, and here's her scan. So what do we see now? Well, we can see that there's been a little bit of resolution, but there's also a few new defects. So she's got this changing pattern of perfusion abnormalities. Okay, what are we going to do now? Her perfusion's still changing even 5 weeks later. You can do a Doppler again, you can watch and wait again, you can have a CTPA, you can get a filter put in, or you could start to worry you're missing something other than your dinner. So the CTPA is moving up in the world, but 25% of people are worrying they're missing something, and I was with that group. Thank you. However, I think it's actually perfectly reasonable to do a Doppler or a CTPA at this point, because clearly there's something else going on here that is not our standard patient. That was my dinner. So in view of all those symptoms, she did have a CTPA. It showed nothing. She had a DVT ultrasound. It showed nothing. We couldn't see any evidence of PE. She came back at 6 months and she still had pruritic chest pain. She was still on anticoagulation. She was still getting febrile and being unwell. And at that point, we got all the scans up and just looked at them all. And what did we see? We saw that she had, over time, I might just use the mouse if I can. No, I can't. Basically, that there are defects that are appearing and going over the whole time course. So that's the purple ones are new ones and the red ones go. So what do we think now? You've got all that information, 6 months worth of VQ scans. Do we think she's got chronic infection, a vasculitis, recurrent small PE? Wake me up when it's time for dinner. Vasculitis. Well done, everybody. Okay, thank you. So indeed, that was her final diagnosis. She has vasculitis. She turned out to be ANCA positive. She was put on some steroids and her symptoms went away. So when you see these fleeting, rapidly evolving changes on a perfusion scan, vasculitis is something you need to think about. And to be honest, I'm sort of a bit sad we didn't think about it on her 3-month scan. It took to the 6 months before we finally twigged. There's not a lot of literature on lung scans in vasculitis. There are a couple of papers out there. One actually had 18 patients who had Takayasu's, and they showed that the mismatch defects were quite frequent in patients with Takayasu's arteritis. And there's a single case report, but there's not a lot of reported literature because it's such a rare thing. Again, if you look at Takayasu's, which is the main group that's been studied, there is certainly some stuff you can find. Okay, moving right along, and this might see who was paying attention earlier. A 46-year-old woman, she's got a history of breast cancer. She's sudden onset of shortness of breath and pruritic chest pain. This is her ventilation and perfusion imaging. This is the planar imaging, and it's sort of doesn't protect too badly, but you can see, if you look at these images, maybe that there is some perfusion abnormalities. This is the SPECT imaging with ventilation and perfusion on top. So I'll just give you a moment to look at those images. So, do we think she's got multiple PE? I'm trying to trick you and giving you a second vasculitis in a row. I do things like that. Is it normal, or has she got some complication of her breast cancer? Okay, well, that's got people thinking. No one bit for the vasculitis, so, okay. All right, breast cancer complications, the top, and next time I'm giving a talk, I'm going to make sure that Dr. Roach doesn't show the answers to my questions. So this lady does indeed have a complication, and that chest X-ray, CT image would be considered diagnostic of lymphangitis carcinomatosis. So lymphatic spread of tumour usually occurs with adenocarcinomas. Breast cancer is the most common, but it does occur with lung, colon and stomach cancers. It's due to hematogenous seeding and microemboli. Some people think it's also due to lymphatic backflow from hyalinode involvement. There's a range of CT appearance, but the main thing you're looking for is these thickened interlobular septi. It's usually bilateral, can be unilateral, and the actual pathology is tumour in the pulmonary arterioles. Again, not a lot of literature on these rare things. There was a review article where they looked at 21 articles that had a total of 32 patients. Unsurprisingly, most of them are female. 58% of them had basically a normal chest X-ray. This is a diagnosis with a poor prognosis. Nearly all of them die within a month. This is another example of carcinomatosis where you have multiple perfusion defects sort of scattered in almost a random pattern around the lungs. I also just sort of give you a quick update just in case you see any of these when you're walking down the street. The funnel web spider is the 7th most deadly animal in Australia. Don't pick that up. If you see a saltwater crocodile in Melbourne, something is seriously wrong. Okay, case number 3. This is a 35-year-old male. He was out playing soccer, a man after my own heart. 24 hours of putting chest pain. He had a chest X-ray that showed a small effusion and some little subsegmental inferior lingular collapse. His D-dimer was elevated for his age. And because of his young age, they decided they would go straight to VQ rather than CTPA. So here is his ventilation and perfusion tomographic images, if you'd like to have a little look at those for a moment and then maybe have a little think about what you think might be going on. Okay, so the options we have, it's just a normal scan with a bit of variation. He's got vasculitis, he's got small PE, he's got asthma. No, it's not soccer, it's football. Am I going? That was quick. So I voted for the football one. Okay. So most people seem to think it's small PE. And if you look at those images, I think... Yeah, the ventilation is abnormal. And I think that's...
this is very important in such cases.
Yeah.
Yeah.
So there are a number of perfusion defects. And he had, because we said, look, there's some match change, it's a mismatch, they sent him for CTPA, it was reported as negative. But being the somewhat obsessive person that I am, I fused the data with the CTPA and we were able to actually show that the perfusion defects correlated with very small peripheral emboli in his lung. And so indeed this was multiple small emboli and he also had some ventilation abnormalities for whatever reason. Snakes, if you're a snake lover, you've come to the right place. Bull sharks, don't go swimming unless you take someone with you to reduce your risk by 50%. The 23-year-old male with chest pain, dyspnea and a non-smoker. He's come for a lung scan as well because he's got this chest pain. These are the planar images that we create. Doesn't project that well, but again, if you just look probably at the anterior images, you'll get a sense of what's going on. So I don't quite know why it keeps doing that. These are his perfusion images. So ventilation and perfusion. Ventilation and perfusion. Okay, hopefully everyone can see the abnormality. So what's he got? Has he got a big left pulmonary PE? Has he got an obstructed left main bronchus? Has he got tumour compression of the left pulmonary artery? Has he got some vascular anomaly? Or could it be almost all of the above? Okay. All of the above's doing well. Okay, thank you. Okay, thanks. Okay, so this is one of the ones where you look at the registrar and say, did you get a good history? And they go, oh, absolutely. And then you walk out and say to the patient, have you ever had surgery? He goes, oh, I only did this heart thing when I was little. And so he'd had hyperplastic left heart surgery as a child. And one of the things that they can do for that is an extracardiac Fontan procedure. And with that, they take the SVC and they connect that to the right pulmonary artery. And they take the IVC and they sort of stick that up into the bottom of the pulmonary arteries as well. So what actually can happen is that the perfusion to the right lung is coming from the SVC, but the perfusion to the left lung can come from the IVC. And if you look at this guy's angiography that he had subsequently, you can see that with the injection from the SVC, there was a pacification of the right pulmonary artery, but nothing on the left. And that's his IVC coming up to feed his left pulmonary artery. And just to prove it, there's his left pulmonary artery and right. So taking good history never hurts. And vascular abnormalities can trick you. The irukandji jellyfish is something up north. It was thought to be the most venomous animal on the planet until very recently. So we might just do one more, and then I think we should all go and have that beer. This is a 47-year-old male who was short of breath. He was a smoker for 10 years. He had a bit of bronchitis, no recent travel. This is his ventilation on the top, his perfusion scan on the bottom. To have a look at that for a moment, see what you think. So this slice here is through the superior portion of that lung field. Okay. And there's his spec CT that goes with it, just to show we do them. Okay. So what do you think he's got? Some left upper lobe PE, an obstructed left upper lobe bronchus, some primary lung abnormality, vasculitis, or is this yet another weird vascular anomaly? We might just go straight to the thing, because we'll try and get it done quickly. So, okay, so the primary lung abnormality and obstructed left upper lobe, I think, are the two main ones. Thank you. So if you look at that CTPA, I think you can see something quite interesting in that he's got a very sort of hypodense lung on that side compared to the other side. This guy is very unusual. He has congenital lobar hyperinflation, which is typically something seen in kids, but we don't see that very often in adults. But basically, it's a obstructive abnormality of his ventilation. And so he's got a large match defect because he's not ventilating that upper lobe with his congenital abnormality. Second most deadly animal is the bee. So don't go near those flowers. And I just have to let you know before we leave, the most deadly animal in Australia is the box jellyfish, or anybody who gets between me and the pub may find there's someone else. So thank you.
On that map of Australia where the post-Congress symposium is being held.
So up here is where Cairns is. This time of year you can swim safely in the water.
They say.
Always take a friend.
Would you join me in thanking all the speakers for an excellent session? Thank you to my co-moderator, and I wish you a pleasant evening.